Hi, I'm Yeong Park. Let me show you the paper with the title of Impact of DGF on Highly Sensitized Patients in Disease-Donor Kidney Transplantation. The development of DGF in disease-donor kidney transplantation was reported to be approximately 10 to 50%. Various mechanisms have been proposed for DGF to be involved in deteriorating clinical prognosis after DDKT, and it is explained that it leads to the progression of chronic tissue damage in allo kidneys. Pre-transplant sensitization to HLA is a very important risk factor for the development of acute rejection and also for adverse long-term allo outcomes. On the basis of the above evidence, if the DGF occurs after DDKT in highly sensitized patients, the likelihood of activating an allogenic immune response increases, and it leads to the higher incidence of allograft rejection and also worse allograft survival, but it has not been fully investigated yet. So we aim to investigate whether the development of DGF in highly sensitized patients can affect the short-term and long-term outcomes in DDKT. Highly sensitized kidney transplant recipients were defined as the PRA level that was equal to or greater than 50%. DGF was defined by the need for dialysis in the first week after kidney transplantation. The primary outcome of this study was the incidence of biopsy-proven acute rejection. Secondary outcomes included changes of allo function, death-sensitive graft survival, and patient mortality. The development of DGF in the low sensitized and highly sensitized groups was 199 and 27 respectively, and there was no significant difference. The proportion of retransplanted kidney transplantation history was significantly higher in two highly sensitized subgroups than low sensitized group. The proportion HADSA was significantly higher in two highly sensitized subgroups. ATG was more frequently used than besilesomab as induction agent in two highly sensitized subgroups. Combined use of rituximab was more frequently performed in two highly sensitized subgroups. Biopsy-proven acute rejection occurred significantly more in the two highly sensitized subgroups compared to low sensitized non-DGF subgroup. TCMR, including mixed rejection, occurred significantly more frequently in the highly sensitized DGF subgroup compared to the other two non-DGF subgroups. Biopsy-proven acute rejection incidence was independently influenced by highly sensitization, elderly recipients, and HLA mismatch numbers above 3 mismatches. The allograft function was significantly lower by 1 month after kidney transplantation in two DGF subgroups compared to the other two non-DGF subgroups. However, in two DGF subgroups, allograft function was improved gradually after kidney transplantation, and there was no significant difference among the four subgroups after 3 months after kidney transplantation. Death-sensitive graft survival tended to be lower in the two DGF subgroups than in the reference subgroup. Patient mortality tended to be higher in the two DGF groups, but was not statistically significant. Summary: biopsy-proven acute rejection incidence was significantly higher in the high PRA DGF subgroup, and high PRA and DGF showed significant interaction for the development of biopsy-proven acute rejection. Allograft function was lower in the two DGF groups than in the non-DGF group until 1 month after transplantation, but it became a similar effect that Death sensor graft loss rates and patient mortality tended to be high when DGF developed. In conclusion, development of DGF in highly sensitized patients after DDKT could have a synergistic impact on the increased risk of biopsy-proven acute rejection. If in pre-sensitized patients, it is necessary to prevent DGF from occurring, and when DGF occurs, it is necessary to control preemptive immunosuppressive therapy against biopsy-proven acute rejection. Thank you for your attention.